This is a really good question, so let's dive into it. So a lot of clinical pharmacists in GP land are non-prescribers. We don't actually sign off prescriptions, the doctor still does that. There is just a structured process how it kind of gets done. So for example, when I carry out a medication review, I'm not issuing or signing off prescriptions. Instead, I complete the full review. I look at the indications, the guidelines, the blood results, the interactions, the adherence, frailty, patient preference, etc. I then document a clear, structured recommendation in the patient's notes. These might include starting medicines, stopping medicines, restarting medicines, dose changes, like an increase from amlodipine 5 to 10 because their blood pressure is not controlled, or that there is an interaction that I feel that's a little bit, dangerous and there's a better alternative, or they're getting a bad side effect and I've recommended an alternative, but regardless, that's clearly documented in the notes. Because these recommendations are documented in the notes, this is going to be quite hard to explain if you don't work in GP. So the medicine is added onto the patient's records, then it gets issued to the GP. So the GP will get it through their task or their workflow management, depends on the system that you use, and essentially the doctor will sign off that prescription. If the doctor sees that there is a higher strength for this patient, they will look into the notes, look at my rationale or the pharmacist's rationale, and decide whether it's clinically appropriate. Most of the time it doesn't really get questioned, but that's usually how it goes. If they're happy, they'll sign it off, but at the end of the day, the legal prescribing responsibility is always on the GP as a non-prescribing pharmacist. Most practices have protocols, or they have a way of how we can work in collaboration where pharmacists can recommend routinely. It would mostly start off with deprescribing low risk items such as paracetamol, let's go for that, or optimizing drug formularies, so switches and things like that, and monitoring adjustments. So monitoring adjustment, for example, the DOAC monitoring. If the creatinine clearance falls within a certain range, we have to increase or decrease that DOAC. Usually that will be something that pharmacists do as well. But they're example of protocols that will most likely already be in place before the stuff that I mentioned earlier. I hope I haven't lost you yet. Over time, as the GP becomes more familiar with your clinical judgment and your documentation, the sign-offs become more efficient. So while the pharmacist isn't actually prescribing, pharmacists are doing the bulk of the clinical decision making, which obviously frees up so much time for the GPs. So obviously this process is much smoother once you're an IP because you don't send it to the GP, you just sign it off yourself if you're competent in that area. But even as a non-medical prescriber, you can make meaningful clinical decisions. I hope that makes sense. I feel like it was kind of clear. But yeah, that's pretty much how it goes in GP land. Any more questions, let me know. See you later.